Hi, everyone. Thanks for joining on this rescheduled Opioid settlement meeting. I'd like to call the meeting to order, and as we usually do, we'll start with introductions and then approve the minutes. Julia, why don't you start with introductions and we'll go around this way.
Sure. Hi, everybody. Julia Harvey, designee from the Attorney General's office.
Everyone, Alex McAdoo, she, her, assistant professor at Brown.
Jeffrey Brown, the fire chief in the town of West Warwick, and I'm the Kent County representative.
Good afternoon, Julie Wilson, she, her, director of substance use treatment services at Thrive Behavioral Health, and serving as an expert.
Rachel Ferrara, see her, Human Services Director with the City of Providence, and I'm the mayor's designee.
Maria Santos, Realtor in Providence County representative.
Patricia Resendi, she, her, Bristol County representative.
Mark Gutnolly, I'm the fire chief in the city of Newport, and I represent Newport County.
Phil Chan, he, him pronouns, representative of the Rhode Island Department of Health.
Rich LeClaire, Director of the Department of BHDDH.
Jake Bazillion, he, him, I represent this area in the Senate, here on behalf of the Senate.
Sean Lacey, representative of Washington County.
And hi, everyone. My name is Brandon Marshall, he, him pronouns. I'm a professor of epidemiology, and I have the honor of serving as chair of the SAC committee with some of the staff. I'll introduce you later, Ben. So we'll skip this. Michelle.
Hi, everyone. Michelle Goncal, Finance Manager at EO HHS.
So Melvin Suthi, the interdepartmental overdose project coordinator at EHS.
Okay, we got everything.
I'm Kathy Schultz,
Yeah.
the director of the.
Everybody knows Kathy.
Everyone's. That's right. All right. Well, thanks everyone for dealing with our rescheduling. The January meeting was a challenge with the snowstorm. None of the parking lots were accessible, so we had to do a last minute cancellation, and really appreciate your presence here today, given that it's the school vacation week for many folks. So appreciate you being here. Let's go ahead and approve the minutes from our last meeting, which was in October. They're in your packet. It's like this. Can I get a motion to approve the minutes unless there's any corrections that committee members would like to offer?
So moved.
Right, so we have one motion, second.
Seconded, yes.
All in favor of approving the October minutes, say aye.
Aye.
Any nays? Abstentions? That motion passes. Great, okay. So we will move along to our agenda for this afternoon. Go ahead to the next slide. So this looks like a very busy agenda. We have a lot of updates for you. But we don't have any items that require voting. And depending on the length of the discussion and the public comment, I don't know if we'll need the full 2 hours today. So I'll try my best to move us along through what are many updates. We'll start with programmatic and budgetary updates from Kathy. And then I have some updates as your chair, following up on some items from our last meeting in October. We'll then go to our first public comment. As a reminder, we always have 2 public comments. And then we'll hear from Ben Hallowell at the Health Department regarding 2025 fatal overdose data. And we'll finish today's meeting with update and discussion on new members for the coming year. We have 2 committee members cycling off the committee. So we'll finish with that in public comment. Okay, so that's the plan for this afternoon. With that, I'll turn this over to Kathy for some budgetary and programmatic updates.
You can go to the next slide. So I am just kind of showing you just some updates. This should look familiar to you. It's just kind of in a different way. What we're looking at here are the allocations for 2020 from 2023 to 2026. And basically where the allocations are what you all voted on over the years. And then we also broke it down by spent. I want to just make a very, broad statement so that everybody understands what spent means. And I want to thank my colleague Michelle for really breaking it out so that we all understand what spent means when we're breaking it out in here. And that is that the FY26 estimated spend right now, the other years are finalized, but for FY26, we're only able to give you, well, FY25 spend, sorry, we're only able to give you the estimated spend. So that's what's in there that has already been billed to DOA, and it's been fully processed and paid. So this does not account for any invoices that may be in the process. So I just want to make sure that everybody is clear about that. So as of right now, from July to what has been paid through January, when we pulled this data, we have about 5.3 million has been spent. And it says through January, but again, that's kind of the thing that is really important to understand is that that is usually most likely December invoices, which some may come late and they may not have been paid yet. So it wouldn't show in that. So we're on track to probably spend similar to what we spent last year. We won't know until probably August, the final spend for FY '26. It also has a lot of things like we have a new system and some of the invoices are taking a little bit longer as we get used to this new system. So I just want to kind of clarify that. And I think that's really all I wanted to share on that. The other thing that's really important is in your packet, you have a copy of the settlement annual report. That settlement annual report is broken down by allocations as well. And also spent. So again, that is the allocations that you all voted on and approved. It's not necessarily the budget items. So the budget can change and have some transitions here and there based on, just line items. But as you can see, that'll give you an update of some of the programmatic updates, the spent, some of the, language in there kind of explains what we've done over the last year through FY '25. Okay. Any questions on that?
Director. Kathy, a quick question. On the slide, are the allocations cumulative? Or are they just for that year?
Just for that year. Great question.
Great question. Other questions for Kathy? I'll notice while the report has a more detailed breakdown in the table, we didn't want to overwhelm the slides. So there is a more detailed breakdown in the table. And this report is available publicly as well, right?
Yes.
On the EOHHS opioid settlement advisory council website. So members of the public also have full access to this December report.
Absolutely.
Yeah. Okay, should we go to the next slide? So.
Sure. So there's a lot of words here. You have the slides. And I don't want to read all of the words, so I'm going to go over this quickly. I just think that it's important that as we start the new year, even though we had to move this meeting from January, I just wanted to give you all a quick update on some of the high level programmatic updates. This is not everything. I want to remind everybody that there's probably about, and I'm saying this as an estimate, 75 different initiatives and over 150 contracts. So it's a lot of information. So I just pulled out some of the more recent information. So EOHHS has partnered with the Rhode Island Department of Corrections in an MOU. This is an ongoing project. So we have provided $125,000 to the Department of Corrections, which is creating actual like basic needs bags. And I have actually heard from somebody who was recently released from the ACI that they were really excited to have a bus pass and the $25 gift card and some other items. So that's going really well.
Gavin, sorry. Do you know who the point of contact is for that? Just because I'd be happy to reach out to them to coordinate.
The reentry.
It's okay.
program. Yeah.
Heather,
So
well,
it was Heather Gatos.
It was,
I
right.
think she's out right now, but
Yep.
right now it's Lisa Blanchett.
okay. Thank you.
Okay. And I probably should wear glasses. I'm losing my eyesight. Sorry.
I just had to use my phone to take a picture of the
Really?
Wi-Fi thing over there. So.
Losing my eyesight. EOHS has also extended its contract with West Bay to deploy the mobile wound care. This is a project that has been going on since 2023, but we've expanded that project. And we're really working on trying to fill the gaps across the state where there might not be that mobile wound care or street medicine. Woonsocket is an area that we've identified as well as West Bay, well, King County area, so. And next, Rhode Island Foundation, you may have all seen the press release. This is an amazing partnership that we are on our third round. And we are providing, lots of funds, $2.5 million in grants across many different agencies. And we have trauma supports, individual family, community recovery supports and capital, youth community-based prevention, and some emerging issues funds going out into the community to those smaller organizations that are really local level targeted services. Next slide, please. So here is our municipal incentive funds. So this is when really gets us excited, because we heard from you all how important it is that we want to really work with our municipalities and kind of like help them with what they're doing with their opioid settlement funds that go directly to the municipalities. And our first partnership was actually with the City of Providence. The City of Providence is really a great model showing how they're using the strategic plan for the state to really align with the work that we're doing. We also have some expanded programming through that partnership. And I really am excited to share with you all that myself, Rachel, and Dr. Marshall are all going to be joining in the annual League of Cities and Towns annual conference, and we'll be holding a panel to kind of highlight this municipal initiative, incentive initiative. And we have also gone into the second round of that. So there was some additional opioid settlement funds that were still there, and we're opening it up to see if any other municipalities want to join us. Harm reduction, EOH just continues to provide funding to Project Weber Renew. I have to look at this because I can't actually see these little numbers here. And I wanted to give you a quick update on the Overdose Prevention Center. So in January 2025, it was open on Willard Avenue. And the data shows through November 2025, there were 6,619 visits. 653 of those were unique. 159 overdose interventions, approximately 90 non-fatal opioid overdoses, non-fatal opioid overdoses, and over 4,000 referrals to treatment, peer supports, case management services, and other resources. 0 fatal overdoses. And I think that that's the most important thing that we see there. Yeah.
I'll say also, they've only had to call EMS twice.
Thank you.
Which is excellent for the city because that's freeing up our first responders to respond to other types of calls.
Thank you, Rachel. Thank you. I was going to say once because I knew about once, but thank you. Thank you. And the Department of Health has partnered with Rhode Island Hospital to open the Addiction Care Today Act program. This is a post-overdose engagement program that offers same-day walk-in or scheduled appointments for individuals seeking support and or treatment services for any substance use disorder. And I have a little bit of data for that one as well. So since February 2025, there have been more than 1,000 visits to the clinic. From May 2025 to September 2025, 98 unique patients had an initial evaluation with a clinical counselor. 58% were prescribed MOUDs and 33 were given take-home naloxone. So those are some really exciting updates for some of the work that we're doing. And we have one more on treatment and recovery. And for treatment and recovery, Family Services of Rhode Island and Tides Family Services have been awarded startup opioid settlement funds in response to a BHDDH request for proposal to open a gender-specific substance use residential facilities. These projects will provide residential SUD treatment for 10 male and 8 female beds. And then we have BHDH has awarded approximately $200,000 in funding to Rhode Island Public Health Institute for stimulant use treatment to develop and implement an evidence-based stimulant use disorder program to at-risk populations. And then for recovery, BHDH has awarded contracts to 17 organizations for recovery housing that will increase the number of recovery house beds by 218, providing individuals. And then EOHHS and RIDO have awarded Amos House with approximately $397,000 for a restorative oral healthcare pilot aimed to increase oral health rehabilitation services. In number one, people in recovery who, number one, do not have dental insurance, or number two, do not have full coverage as an existing Medicaid beneficiary. And then BHDH has awarded approximately, $297,000 to Ride Cares to develop and implement an internship program that will provide newly trained peers with the necessary hours and skills to become certified peer recovery specialists, which we heard very loud and clear. That was a very important thing that we needed for across the board, including the CCBHCs. So I know it was a lot of information. Director?
Hey Kathy, I just want to make sure, the treatment, that first bullet, it doesn't state it, but that's for adolescents. Those two programs.
I think it says youth. I'm sorry if I didn't put that in there. Okay, thank you. I'll definitely fix that before we put it online.
It's noted as such in the report, Kathy, so I think it's there. Yeah, 12 to 17-year-olds, I think, is the target population.
I should wear my glasses. I could probably read it.
In the report, okay.
Yeah, in the report, it's there on the side. Other questions or comments for Kathy? Okay. So these are some of the new funding or updates.
Yep.
The full breakdown of all of the funded programs are available in the December report, but we just wanted to give you an update on some of the new activities and the new contracts. We'll continue to do this at our future settlement meetings as well. So thanks, Kathy, for putting that all together. That's really great. Hey, so I'm not seeing any other questions for Kathy. I'll move us along to some of my updates then. Go ahead to the next slide. So I just have a few high-level updates for you, and then I wanted to have a discussion, update and discussion on the Purdue settlement, which is still in process. Next slide. Okay. A few updates from our October meeting. If you recall, we had a robust discussion and vote on supplementation guidance. And also from that discussion, a recommendation for me as the chair to write a letter on behalf of the committee that went to the governor and other leadership in the state about what we had been up to over the past year and to highlight that guidance. So I went ahead and did that. I want to thank you for that recommendation. A copy of the letter that I sent in early January is in your packet. It's here and also available online. I essentially summarized the activities that we had discussed, that we had updates on over the prior calendar year. I also highlighted and we attached the supplementation guidance, which you voted on in October. And then I also emphasized that any changes to the allocations, which we previously voted on, would require a presentation at this committee and a full, robust process for discussing and voting on any of those changes, including time for public comment. So that is, I think, on page 2 of my letter that I wanted to point to folks based on the discussion in October. So that was circulated in January. Okay, next slide. So I just wanted to highlight as well, we now have an approved supplementation policy that we voted on in October. This is a part of the policy that you see in the slide. In essence, this committee does not endorse supplementation as an approved purpose, which is defined as the deliberate replacement or kind of like swap of existing federal or state resources with opioid settlement funds. Rather, these funds are meant to be value adds to extend existing projects, to increase their reach, or to fund new projects, essentially. You go to the next slide, so. One recommended change to the guidance, which we discussed in October, that I just wanted to highlight, was to explicitly reference both the MOU between the state and the cities and also the actual legal agreement. And to highlight that this guidance should not override basically those legal agreements. So that language we inserted and is available for you in the quotes here. And there are also links in the online guidance to both of those documents, the MOU and the actual legal settlements. So that is available there. Basically, it says the guidance should not replace or conflict with, but rather is designed to complement the terms of the MOU, which can be found there, and a detailed overview of the allowable uses is also available. So that was added post-approval, and I just wanted to close the loop on that for the committee's awareness. Okay. Any questions about supplementation before we go to the Purdue settlement? Great. Okay, let's go to the next slide. So perfect. And then slide 15. So I wanted to share a few updates on the Purdue settlement for you. This settlement is still in process. We've spoken with some representatives from the Attorney General's office, including Julia, about where we are. So please update me, or please correct me, Julia, if there are any updates since we last had our discussion. The funds will likely come into the state in the third or fourth quarter of this calendar year. So we do not have those funds in hand yet. What we do know so far is as follows. The state will receive a single lump sum of this payment. So it will not be amortized over the 18-year time horizon, unlike the other settlements, which were all over that time period. So that gives us as a committee really maximal flexibility on how, not just how, but also when we choose to allocate that funding. So that is really important to note. The total amount will be 80% of the total settlement, which is 27 million and change. So we as a state committee will allocate about $21.6 million, about 80% of the total. 20% of the 27 million will be apportioned to the cities, the 39 cities. I assume using a similar formula, Julia, do you know, is that correct?
Yeah, so any of the allocations, that is all governed actually by the MOU that Dr. Marshall had referred to previously. So that governs the allocation between the state and the cities and towns and also among the cities and towns. So it'll be the same distribution percentages as with previous settlements.
That's right. So we will receive 21.6 million or 80% of that total. Okay. Go to the next slide, Sil. So what we are doing now is as follows. Opioid settlement staff and others at the Attorney General's office are currently investigating what some of our legal options might be for investing these funds. We are trying to determine if and how the funds could be put into some kind of investment vehicle. That might include something like a fixed term annuity. These are set term investments that would generate interest, but would be designed to be spent fully down over some time period. They might be more like a low risk interest bearing account, like a savings account, or more of an endowment, for example. There's a lot of nuance here and challenges. We don't yet know who would actually be responsible for managing that account. There are potential things to think about, like the fees associated with managing such investment vehicle, and also penalties if we were to need to withdraw funds to address some emerging issue or crisis. So what we would like to do is find the answers to those questions, present all of that information to you so that you can make the most informed decision possible on how to actually allocate these funds. What our goal is at some point later this year is to present you with a menu of options, basically, to say, here's what we think we can do, you know, and would love your feedback. At the end of the day, you as a committee will decide and vote on what actually to do with this $21.6 million. So any strategy that we pursue would require approval by this body, of course, with public comment. Okay. I have one more slide, and then maybe I would love to have a discussion on this. I want to go to the next one. Thanks, Sil. So I just wanted to get all of you thinking. We don't have to make any decisions today. We're still doing a lot of this research, but I just wanted to get you thinking so that when we have this discussion, you're fully informed. This is a slide that shows several things. In light green, it shows when the state has actually received funding by fiscal year. So I want to note that those dollars per year do vary from the slide that Kathy showed, slide 5, I believe, earlier. And that's because when we actually allocate and vote on some funding, ends up being sometimes different than when the state actually receives the money in some kind of account, which is what's shown here. But at the end of the day, you do vote on every single dollar. It's just that there are differences between when we actually vote on the allocations and when the state actually receives the funds. So for example, we actually received $6.3 million in fiscal year 2022. This body wasn't even constituted until I think the next fiscal year. So that money was allocated in the next fiscal year. But at the end of the day, I do want to highlight that the totals to date between fiscal year 22 and fiscal year 2026 sum up in both slides to about 70 million. So in total, there's been 70 million received and allocated to date. So that's the light green. The dark green is actually from the spending from the earlier slide that Kathy presented on slide 5, just to show you how the spending has actually been ramping up in the last couple years. And in the last fiscal year, we spent about $11.3 million. And that is emphasized, we just drew a red line to emphasize that amount. And like Kathy mentioned, we don't know what our final spend is going to be in this fiscal year, 2026, because we're only halfway through it. But we think, to the best of our knowledge, that it will be about 11 million as well. So my intent with this slide was to show you that very quickly we're going to be entering an era where the amount that we receive is less than the amount that we are currently sending out the door, which is a new era for us, right? In the last couple of years, it's actually been the opposite. This does not include the Purdue settlement, so that's why I wanted to highlight this piece. The final thing I wanted to highlight as well is that we will be fine for this year because of the carry forward from those years where we received a lot of funding, fiscal year 2023 and 2024. And the final thing that Kathy likes to remind me is that it's not like this money is all available. The vast majority of it, say 90%, has been encumbered or obligated, just not spent yet. So it's a little deceiving, right? This is not like the difference between the light and dark green bars are all just available. Much of it, most of it has been encumbered or in contract or what have you.
Or obligated.
Or obligated.
Yeah.
Yeah, to causes. So that was my goal with putting up this slide, is to give you that high level overview and just to show one of the options of the Purdue settlement is to basically use the Purdue settlement to try to narrow that gap between the amount that we are currently spending and the amount of the current settlements that we'll be receiving in the out years. Even if we did that, 21 million would not go that far, right? It would not fill that gap all the way out until fiscal year 3039. So just to get you thinking about this issue, and would love any feedback or questions. Maybe a question for you might be, what additional information might be helpful that we could generate when we have this discussion about? Yes, Senator.
I think that's a great idea, what you touched on in the end. My question would be, as part of that settlement, are there any stipulations as to how much we have to spend immediately? Are we allowed to put it into a reserve account and draw it down over time, or does a certain amount have to be out the door? I don't know, maybe the answer is no, but I'd like to know that before I'm making a decision.
Do you know, Julia, offhand? My understanding is that we have maximal flexibility over when the funds would be spent.
Yes, so we do have flexibility over when the funds would be spent, and we're in close communication just to make sure that anything that would be proposed would be in line with the language of the settlements.
Okay.
Alex?
Yeah, I was going to say that across options, and we discussed this later in this fiscal year, across options, projections of the estimated interest, should we pursue that option,
Okay.
and projections of how this might help us to top up over the coming decade plus would be really wonderful to be able to take a look at.
Yeah, that's great. Yeah, Dr. Chan.
Yeah, thank you, Dr. Marshall. We had a conversation with the health department and I think are generally favoring an investment option if that's feasible, pending the questions that you raised. And I will say, just from personal experience, being part of some nonprofits, first off, the funding is going to decrease. And I think the troublesome sum is when there's a steep cliff drop off. And so even if we level funded things for a period of years, you're then going to have the cliff. And I think if we can have some funding in, forever, long term, that will help, and we can allocate it. I think to explore would be if we can allocate it on different amounts per year, depending on the need. So we can try to, as we off ramp some of this funding, if we can have a smoother curve and frankly provide less disruption to services. And at some point, we're going to have to pick some that we want to continue funding. And I think that was always the vision, is that as fatal overdoses, as we've gotten a handle and hopefully continue to get a handle on fatal overdoses, is that we're going to have to choose and invest in certain things that work more. So I would favor a strategy where we try to limit the funding, the off ramp, so it's not a steep cliff. And I see this as continued investment forever, potentially, in terms of at least providing some money to efforts for opioid use.
Yeah.
I think it's a related point to what Dr. Chan was saying, which is that it might be useful to see options that offer solutions for different goals that the OSAC may want to pursue. So for example, there may be a goal of, as you said, trying to keep up with our funding amount for some period of time, or there might be a related but perhaps different goal of extending the funding out for as long as possible, potentially in perpetuity. And so understanding what solutions would be available for those or others would be helpful.
This is great.
I think if I could just add to both your points and everybody's point, I think what's important to remember is an example is the youth, and by the way, I fixed that for your director. Thank you for noticing. For instance, we have a brick and mortar startup that is going to be, the project will continue through Medicaid reimbursement. It's a startup and it's brick and mortar. We have increased a tremendous amount of beds, residential beds, which was startup costs. So they cost money at the beginning, but then as time goes on, those aren't going to be some of the expenses unless we need more beds. And also a reminder that in 2023, we partnered with the Office of Management and Budget, OMB, to do the FY23 budget survey. We did that again in FY25, and it's about to be published. So once that helps us see the whole picture of what is funded by Medicaid, what is funded by grants, what is funded by opioid settlement and stewardship. So that is also going to help you all to make those kind of decisions. That's kind of tangentially why we partnered with OMB to be able to do that. And our state agencies, BHD, HRIDO, many other state agencies beyond under the EOHS umbrella participated in that. And I want to thank them for the hard work of completing that survey.
Yeah, so we would be able to contextualize this decision within that other spending that would be cool.
Yeah, and also federal changes too.
Yes.
Can't forget about that. So
yeah,
that's another thing to take under consideration because, you all are, here and you're experts, you're learning, whatever it may be as you go along. And we want to make sure that we focus on evidence-based practices and that we sustain those kind of things. The one, area that I think about is treatment. The good news is, even though we didn't know the federal changes would happen, we are working very closely with Linda Mahoney at BHDDH on a regular basis to take a look at, a funding line that we actually have for uninsured and underinsured folks, because that's important, right? We know that we need to maintain that. So it exists.
Yes, Dr. Chan.
One clarification about these settlement dollars.
Yeah.
Does the committee decide itself, or do we make a recommendation to the secretary of EOHS? Who decides?
Technically the latter, right? Thank you, Misha. I misspoke. Yes, we recommend, and then the final say is at the governor's level or secretary and governor's level.
And we do a memo that really helps to put your recommendations in words so that we help the secretary make that decision.
Yes, Director McClure.
Now, Kathy, maybe you were saying this before, but is there a way of finding out what are the one-time spends in here so that we can get a true picture of maintenance of effort?
Yep.
So we'd be better able to forecast what we need to do in terms of sustaining in the future if we had no other startup or one-time spends.
Yeah, I think it's not as detailed in this report, but it's pretty cut and dry. It wouldn't be a heavy lift to do that. And we can do that across the agencies. So we'll talk about that with the agencies. It should be easy. And I can just confirm with BHD, TRIDO, any of the other agencies.
That's right. And Julia, I liked your point. I just want to fully understand your suggestion, which was to start with a solution or the goal.
Right.
So to say, if the goal is to have the money be extended as far as possible, this is what we think the strategy would be, say an endowment. If the goal is to just level set funding at 11 point some odd million for 18 years, this is, so is that your
Exactly, yeah.
suggestion? Start with the goal and then generate options based on achieving those.
Right.
That's great. I like that very much.
Exactly. And
Yeah, yeah.
Perhaps also ensuring that like it with that, I think gets very much to Dr. Chan's point, like be lovely to get to see like into this long term, like that gentle, for example, a goal of eliminating cliffs, I think is a really worthwhile thing for us to take a look at.
That's great. I spoke with a few health economists at Brown and Harvard, and another, I guess I just want to get the committee's temperature on this. Another way to think about the $20 million is to do something with it really large, right? That is because we have it all coming at once. In theory, you could say, we're going to do something really significant. I just want to get the committee's temperature on whether that is an option that we should strategize around and even pursue. So this could be like some large infrastructure investment. Yeah, Kathy. I just wanted to. It was brought up in discussions with some of these economists. It's like when you see a big dollar sign all coming all at once, that is one option. Any immediate reactions to that option? Yes, Director.
I think it'd be a worthy thought experiment to go through.
Okay.
Obviously, it would depend on what the project is, and maybe it's not an all or none, maybe it's half, but a substantial amount that can take us in a new direction if we wanted to, that we would not otherwise be able to make. We may decide not to go that way because of the need for sustainability into the future overrides that. But at least it'd be interesting to see if there was such an idea that was being discussed.
Nationally, there has been some states, I know that Massachusetts and I believe Connecticut, I will double check on this, but I believe they put a substantial amount of money, or I know Massachusetts did, in housing. I'm not saying that you all should do that, but it's a social determinant of health. That is a pretty big deal, but we would need to then look at what housing, our Executive Office of Housing is doing too, because we don't want to duplicate efforts. And that's just an idea, right? Like a thought. And then we also have primary care, I'll say it for Dr. Chen, that needs support because it's true, right? Primary care and integrating behavioral health and primary care, our, behavioral health system, our workforce. Those are just some things. I'm throwing a whole bunch of ideas. I'm not in one direction. We all know housing is secretly my thing, but I'm saying this because when we did the strategic refinement, we also, if I didn't announce it, and I probably should have because we haven't met, some of you go to the Governor's Overdose Task Force or the work groups, but it was announced. It's on the Prevent Overdose RI website. We did a strategic refinement, and what we actually saw were those drivers. And those drivers are the things that are really those basic needs and the social determinants of health workforce, housing, basic needs, transportation, all of those things kind of came out throughout the whole process. So.
Yeah.
And not to introduce too many options, I apologize in advance, but it also doesn't have to be all or nothing. Theoretically, we could split it in half. Take half and do something moderately big, like moderately big into housing or some other social determinants or some other XYZ that we identify, and potentially use the other half to do essentially like that cliff elimination to keep us from experiencing too painfully that future pain point of a sudden drop in available funding. So a mix is an option. Sorry for more options.
That's right. Yeah.
And the only thing I would encourage folks, I think if we could solve the housing crisis tomorrow, all of us would be like, oh my God, look all that money spent. I would just be careful to say that I think the more specific, detailed idea, the better, because I feel like if we just put 20 million towards housing, it's going to go into a black hole and we may never see it again. So I would just say, we built, X number of new housing units right here, and here's a plan, blah, blah, that's really going to make a dent in the housing crisis, then I think that's a level of detail that I would be looking for.
Yeah.
And aligning with the other entities that are doing that work too, and making sure that we're not duplicating efforts and we're, seeing it, if you're talking about anything, right? We just want to make sure, looking at if it was treatment, Medicaid, right, and the reimbursement rates and all of that, policies, all of that stuff. So, and really getting into the details to understand it clearly.
That's right. Julie, do you happen to know, will it have the same set of allowable uses as the current agreements, or do we not know? Like, we will have to follow the terms of the
We'll
agreement.
certainly have to follow. So this money will have terms that are preserved in the Purdue specific settlement agreement for specific abatement uses. My understanding is that they are very similar to abatement purposes that we've seen in the past. But that will be something that once everything is finalized, we'll have that available so we can evaluate anything against that specific abatement
That's
list.
right. And that might help address the issue, Dr. Chen, you're raising, that it might not be allowable to spend the money on sort of a broad strategy. I assume it would have to be directed towards abating the opioid crisis.
Yeah, so it will be connected to abatement, though, of course, as we know, that is a large umbrella. So we would just have to take a look when we see it.
That's great.
And I do want to say one thing, because as we're talking about this and it's important just to put this out there, kind of going back to like what we talked about a little bit earlier is, you know, and Dr. Chan had said it, it's about there's infrastructures in place that need to be sustained, like our centralized naloxone hub, for instance. We know that the increase of naloxone being distributed in the state is evidence that shows that that is helping to drive our numbers down, and it literally is saving lives, just as an example. But there are other things that are infrastructure focused initiatives that are being funded by opioid settlement right now, that we just need to make sure that we don't, that's where we don't want to see cliffs on those kind of things. So.
Yeah.
Are there other settlements like this on the horizon?
So currently the only other settlement that has been announced is a smaller settlement with a number of generic opioid manufacturers, which is just about to be finalized. It's only in the amount of about 3 million between the various defendants, and that I think we are also expecting to be paid out this year, but no date yet. And that's all we've got for now.
Great question. Thank you all. Any other questions? It's been a very helpful discussion. We'll do some digging and try to generate some potential solutions for you to debate, options, strategies, etc. Okay, so we'll now move into our first public comment. We thought this would be a good time to pause for public comment, given all of the material and discussion. We will have a second public comment at the end. Maybe we'll start in Zoom if there are any comments from our audience. In chat or?
Does anybody that's on Teams have a public comment? Please raise your hand.
Okay. Then we'll go to the room. Got 2 attendees. Hi, Linda. Hi, Tommy.
Comment right now. It's the first time.
Are you?
It was beautifully done. Thank you.
That means a lot. Like,
gosh, this is great. Good as well. Okay.
You have a public comment?
Could I make?
Of course.
Sure.
The one thing I wanted to mention, looking at that slide, that's a non-monetary value, was as part of the settlement, we get 50,000 naloxone kits each year for 10 years, which has a market value of about $2.5 million. And I know Dr. Marshall's team has shown that there's about 4,000 overdoses a year that are reversed in the community that never seek medical care. And starting in fiscal year 32, all of that naloxone will be gone. I just wanted to mention.
And we have the naloxone centralized hub that's be able to collect the data so that Dr. Marshall's team can analyze it. And that's what I was talking about. So thank you, Ben, for adding to that. Yeah.
So that's a TEVA settlement, Ben, that ends in 2032.
I think 2031 is the last year.
Is the last year. Interesting. Okay.
And I guess a follow-up question, does that go generic eventually? And
it is generic.
It is generic. So, okay, I guess we could cost some of that out and look at options.
Yeah, we also get buprenorphine from that TEVA settlement.
Yeah.
And the good news, I should announce this, you should all get an update of it, it's not in the slides, but the good news is that we are working actually with Kodak to be able to use the buprenorphine in the DOC. It took a while, but they're going to start to do that, or they are starting to do that now. So that's gonna be, that'll help with like medication costs. But it'll help to use some of that to have a settlement because it's not only naloxone, it's also buprenorphine.
Yeah.
Sorry, just, I'm sorry.
Yeah.
I did have some.
We are.
It's worse, yeah.
I just wanted to reiterate when I heard, I mean, I get excited to hear about $26 million too. You know. One of the things, and I know that I've said it before, I'm going to continue to say it for a while, is that it isn't just overdose death that we are looking at now. Longitudinally, over time, when someone has had, people come to us, 5, 6, 7 overdoses in a 3-month period. Each time they have one, it's a brain injury. So it's like your kid going out and getting 8 baby concussions, so to speak. I mean, that's how we think of it during a football season. And how does that add up? And we really need to think about this in terms of, you know, the opioid settlement and the outcomes and the support we're going to be needing. Of course, I'm thinking of treatment. I'm thinking of long-term care for individuals that have had gaps of 2 minutes, 3 minutes, 5 minutes. But there's a lot that we're starting to see. And I think I offered it to you. Tom McClellan and Nora Volkol wrote something, published something like 3 months ago, really, really strong on this that makes a whole lot of sense. So I don't know, should I send it to you, Kathy?
Yeah, send it to me and I'll send it to the group.
Yeah, it's really worth checking out, and we need to be prepared for this because we have individuals all over the state all the time that have naloxone now, and they have them in their tents, they have them everywhere, and we have no idea how many people are having these events over and over and how it's impacting.
Thank you.
Such a great point, Linda.
Yeah, I think that it's important to remind everybody too that I do talk about saving lives and, you know, because it's so easy to measure. It's so much easier to measure than thinking about improving people's lives, to Linda's point. That is actually the state's secondary goal, is how are we improving people's lives? So that's just something to think about. And we really are trying to focus on that a lot. In, you know, all of, you know, across the state. I say the task force just because it's a central place, but it means much more than outside of the task force and the work groups. But it's something that we talk about across our state agencies as well. And I'm sure everybody here is thinking about how are we improving people's lives.
And just to emphasize that point further, the settlement agreements are not written with the sole directive of preventing overdose deaths. It is to abate the overdose crisis broadly and to provide support for people who are generally affected by or impacted by the overdose crisis. So, you know, this is completely in line with this committee's vision. I would say, Linda, is exactly what you're saying. Yeah. Great. Okay. And then also to summarize, we have our contact form that's available. We received 3 inquiries since our last meeting, mostly just logistical about when meetings were, et cetera. And 1 comment is being redirected to another agency that's unrelated. Okay, great. So I will move us along. Then we'll have 1 more public comment at the end. I'd like to invite Ben Hallowell to come up now and give a presentation on updates on overdose deaths. Ben is the substance use epidemiology team lead at the Rhode Island Department of Health. It's a close friend and colleague of mine. So take it away, Dan. Would you like a microphone or?
I can just talk.
Okay, sounds good.
Thanks for having me this afternoon. Thank you, Brandon. Yeah, so this presentation is on fatal overdoses between January and June of 2025 and was originally presented at the Overdose Task Force in January. As I'm sure you're aware, fatal overdoses take about 6 months for the medical examiner to close them. So that's why we're looking at this time frame now. I just want to remind everyone that the data for fatal overdoses in Rhode Island comes from the medical examiner's office, and we strictly report on accidental overdoses. So overdoses that were determined to be suicide or murder are excluded from these cases, but do represent a small proportion of those deaths overall. Next slide, so thank you. So as you can see, this is the number of overdoses that have occurred in Rhode Island from 2009 to present. Starting in 2022, we've been seeing a decline in overdose deaths, and we've had 130 confirmed fatal overdoses from January to June of 2025 so far. Next slide, So this slide is a little bit easier to read and breaks them down by 6-month increments. So we have the year on the x-axis and the number of fatal overdoses on the y-axis. In the dark blue portion of each bar is the number of fatal overdoses that occurred between January and June of each year, and then in light blue from July to December. So you can see it changes year to year. From January to June of last year, we had 193 overdoses, which decreased to 130 this year, which is a 33% decline in fatal overdose deaths compared to the same time period. In opioid overdose deaths specifically, we saw a decrease in 29%. The medical examiner is almost done closing Q3 of 2025, and we're anticipating about a 40% reduction compared to last year. So hopefully this trend will continue. Next slide. So as part of the fatal overdose data, we break it apart by different sociodemographic characteristics, one of which being race and ethnicity. This graph shows the rate of fatal overdoses by race and ethnicity for the first 6 months of each year. The yellow bar shows the rate for non-Hispanic Blacks, green bar, Hispanic or Latino individuals, light blue bar, non-Hispanic white individuals. And you can see from 2023 to 2025, we've seen some decreases across all race and ethnicity groups. This data does fluctuate as the year goes on. So this data, when we present at the end of the year, may be very different in terms of rates, but overall, we're seeing a decline in all groups. As you can see, non-Hispanic Black Rhode Islanders continue to have the highest rate of fatal overdoses when compared to other groups. Next slide. So if you need any more information on fatal overdoses or non-fatal overdoses, we have all the data available and we update it daily on the RIDO's opioid and stimulant use data hub. This data is also synced to prevent overdose RI. And so when we update, both systems are updated at the same time. And then I think there's one more slide of resources, and that's all that I have, but happy to answer any questions.
Steph, questions from the committee?
The only question, just for clarification, that's all substances, right? When the 33%, when you're doing the OSME, the fatal overdoses, just to clarify that the state looks at all substances, including alcohol, is included in there? Or no?
If it was only alcohol, it's not included, but if it's alcohol with opioids or alcohol with cocaine, then it would be included.
Thank you.
Yeah.
If you happen to know offhand, are you able to briefly characterize the difference in like the composition by type of substance between races or across racial groups? For example, we see articles about significantly greater burden, by rate among non-Hispanic Black folks. Is that disproportionately stimulant involved?
Yes.
Yeah.
I have the data on my phone.
So while Ben gets that data, just so you know, Alex, this was presented with a deeper dive in the January task force. So if you're interested in seeing the deeper dive of the slides, it's in the presentation.
Thank you.
Archive. But go ahead. Yeah.
Very high level, 94% of deaths among non-Hispanic Blacks involve stimulants. And then compare that to 54% involve opioids for non-Hispanic Black individuals. If you compare that to Hispanic or Latino, 91% involve opioids. And then that drops to 70% involve. So there's definitely variation in some type by race and ethnicity.
Thank you.
Questions for Ben? I actually have one, Ben. Sorry to keep you up here.
Okay.
Have we looked at fentanyl involvement? If you go back to slide 21. So the red is all opioids, right? Which has been declining, although it looks like in 2025, the proportion that are opioid involved might be going up again. But I was wondering if we look at fentanyl specifically, has that been declining dramatically, or is that maybe one reason for that decrease the last couple of years?
Yes. So far in 2025, we're seeing the same proportion of fentanyl involved deaths as we saw in 2024, which is 61%. So stimulants are now the number one for, let me backtrack. It's very close with cocaine. So in 2025, 61% involved fentanyl, 58% involved cocaine. And so it used to be that like 85% of overdose deaths in Rhode Island involve fentanyl specifically, and that has been going down over the last few years.
And it's all laid out in the January
Yeah.
slides.
And we break it-
It's an in-depth, or deeper dive in that data
Mhm.
presented.
We go by every subs.
Dr. Chan.
So thank you, Ben, Dr. Hallowell, for leading this. Great data, as always. I think just a comment, I think what's most striking, first off, it's a 33% decrease compared to the first half of 2024. That's wonderful. But I think just to explicitly call it out, I mean, that's largely driven by decrease in fatal overdoses among white people and Hispanic Latino. So what we're not really seeing is a similar decrease in Black African American folks. So like at all. So I think that just should give us pause and something to think about as we move forward. And to understand why and what we can do to address some of these disparities.
Thank you for calling that out. The good news, well, not the good news, but what Dr. Hollowell had said is that the data could fluctuate. It's really in June is when we expect to see the final. So that will be presented at the Governor's Overdose Task Force. And I will continue to remind you all. And we can always send the presentation. I think when we send reminders, we do put links for that stuff. And if you can't make it, they're recorded and you can also look at the slides. And we'll make sure that we're intentional in sort of highlighting it for you all so that you see it all in real time.
Great. Well, thank you, Ben. This is super helpful. Appreciate your time. Our goal in presenting this to you was just to keep you updated on where the state is at in terms of trends, but also sort of getting back to Linda's point that if we continue to see these rapid decreases in overdose, it may influence some of your recommendations in terms of where the focus is as we maybe need to support more people in treatment and recovery compared relatively to addressing the acute crisis of overdose deaths in the state. So that was my intent. Our intent was just to present these data to you to get you thinking about maybe a world where overdoses are, fatal overdoses have decreased significantly such that some resources should be focused elsewhere.
Could I just offer a comment?
Yes,
So,
please do.
I was, I guess, 3 weekends ago, I was down in New Orleans, been selected to be part of the National Conference of State Legislatures Opioid Policy Fellows for this year. And so there's gonna be plenty of research, which I'm happy to share with the folks here. But that is the national trend, 40%. And the folks from a range of different places, the leading reason that they said was access to naloxone. So they just want to make sure that everyone keeps that front and center in terms of preventing overdose deaths. So just thought I'd share that.
Thank you for representing us there.
Yeah.
No, I will thank Val, thank the Senate President, not me.
That's great. Okay, great. So I'll move us along to the last part of the agenda. If you could go to slide 27. So that would be great. I just wanted to give the committee a roadmap for our goals over the coming year and actually get feedback on this as well if there's anything else you'd like to achieve. We will have continued discussions of the Purdue settlement as we learn more about these different strategies, what is allowable, and the timing of the receipt of this funding. We will communicate that back to the committee. I'll return to that second point in a moment. We also need to vote on new members. That will happen actually in March. We're going to continue to keep an eye on federal changes specifically to substance use policies and around Medicaid. So like Kathy alluded to, we're collecting that information now, and then we'll present that to you so you can get a picture of how this funding fits in the broader federal picture specifically. So that's going to be very important for us this year, especially given that the Medicaid changes go into effect this December. Is that right, Kathy? The HR 1 bill?
I honestly don't remember.
It's up.
Is it October?
October, November.
I wasn't sure.
I mean, it depends on which changes, but they're rolled out over a number of
The
years.
work requirements, I think
Work
is the.
requirements, sort of is what I was referring to, Julia.
For some reason, I thought they only went into effect 2028, but now I'm
Maybe,
second
yeah, I
guessing
don't-
myself.
Okay.
So I think to that point, we do have a federal advisory committee that is
Yeah.
an executive order by the governor's office. James Rajat sort of leads that and prepares it for the secretary. So we could potentially have them provide an update and maybe in our next OSAC meeting if we have time. If we don't have time, we could do it in April. I can find out because it's in the same office as it's in the OHHS and ask James to provide us with an update.
That'd be helpful, I think, Kathy, just because there are several changes that are being implemented at different times, I guess. Yeah, okay. And then as we usually do in May and June, we'll hear from task force recommendations, which Kathy and her team synthesize and present. We will also hear from our state agencies on their very detailed programmatic updates. And then we have a busy summer as always, July, we put together some recommendations for you, and then the vote has to happen in August for the FY 2028 allocations. And then we take a break. So that's what's coming up this year. I want to return to that second point and then get your feedback on this plan. If you go to slide 28, so we have two members who are cycling off this year. We have our community representative, Miko. He's not here today. His last meeting will be in May. He completes his 2-year term. And then one of our expert advisors, Dennis Baylor, will be cycling off. He completed a 4-year term. His last meeting will be March, actually. So we have 2 slots open. These are slots that are voting slots or that this committee votes on. One community, one expert. Go to the next slide. So I just wanted to review the process for everyone. So we are going to follow a similar process as last year. We have applications, an application form that is now open and available on the website. I'll ask that we'll share that link with you directly, and I ask that you please share it widely in your networks so that we have as many applications as possible. We'll also be sharing this on the task force mailing list and other resources. The applications are due at the end of this month, I believe, Friday.
They're already
the
live.
27th. Yeah, so folks have about 2 more weeks to submit their applications. And that is because we want to then get the applications to you for review in March. So we'll send you their complete applications. Those packages will go to you. And then at the March meeting on March 25th, we will have short presentations from applicants who wish to present to us. And then if you recall, last year we had a closed or executive session on voting. And then we brought members of the public back in to announce the results of those votes. So that's the process that we'd like to do again, but open to feedback on this in a moment. The criteria, we also thought we would remain the same. I think it worked well, although would love feedback. Essentially, we're asking you to consider 2 key criteria: the diversity of perspective that an applicant would bring to the committee, considered broadly and in reference to the current committee's composition. And secondly, the depths of experience or expertise, also broadly, but vis-a-vis the overdose crisis, that might be professional experience, lived experience, or a mix of both. So those are the 2 criteria to keep in mind. The application also contains some basic demographic information and organizational affiliation, if appropriate. So that is the process, but would love feedback from all of you. This is really your process that we guide. So I'll open it up now to any comments or suggestions on what's in store for the year, I guess, and for the plan for voting new members in March.
One thing I just want to remind everybody is that we get in the last few times when we get the applications, we get a lot of applications. So when we send this out with the criteria to vote on, we're most likely going to ask for the top 5 for each of the different categories. And then those will be the folks that we reach out to and try to give them a couple of minute kind of short pitch to the committee.
Thanks, Kathy. So the committee's job would be to review the applications in advance of the meeting and then send in the ranking. The top 5 average are invited to present. Yes.
Just some minor feedback. I remember last year, there was a little discrepancy. It wasn't necessarily clear where if someone was the application wasn't a community representative or an expert representative.
Yep.
And I think we had a little bit of confusion on who had to sign the disclosure of,
Yeah,
it was,
thank
you know, so that was it. But other than that, it was great having them and we had plenty of time to review them. And so I thank you for that.
I think that would be, let's start with the conflict of interest. That was just something that was like a logistics thing, just as a team, which it isn't a bad idea. But does everybody still feel that we should do that? That way we can address that. We'll do the conflict of interest. I mean, we're just using a sort of a form template one, so it's a little interesting. Because I got a couple of questions, I'm like, good question. But it's what we have here in the state. So I think it's just more of a, just to make sure that there's no major conflicts with one of the applicants. And then I want to apologize on behalf of EOHHS. That was more of just clerical that there was, and we're going to make sure that that doesn't happen this year. Thank you for raising up those things.
Yep. My only question about the conflict of interest, I wasn't sure what we were measuring. Because we don't award
That's
it.
what I'm saying.
And, we're all wear different hats, so I just wasn't sure by asking somebody to sign something, what are they attesting to in their conflict? So if it's not precise, I didn't feel compelled that we should do it.
I think the main, from what I've learned from this is you want disclosures, right? So we don't actually, I don't determine if I have conflicts, like someone else determines if I have conflicts, but I need to disclose everything that I'm part of and then
Disclosure.
someone else determines.
Yeah, disclosures.
Yeah.
More
makes
than.
sense.
Maybe we could just add something and just ask that folks just to give any disclosures.
That's, I recall we had the form and then they said, oh, no, you don't need the form. And we just had to send like a statement when we submitted
Yeah, I think.
our reviews. Like, for example, I had a very close friend who applied and I said I abstained from reviewing this application. This person is a close friend, like within that statement. And I think that worked because the form was not a good fit in terms of what we were doing, but I think just that disclosure statement to say,
Yep.
I think that was sufficient for like what we as a committee are seeking to achieve with that.
Yeah, and I think it would also be helpful if in the email, we also provided like maybe clarification of what constitutes maybe a conflict or when to make a disclosure. For example, I anticipate that I might have colleagues, for example, who may apply to that position, but I'm not sure if a working relationship just, together at Brown or at the same center, would constitute. I can disclose, but maybe just clarification about what to disclose.
I think it was just a statement to Rachel's point. It was just a statement that if there is any kind of relationship that you feel you want to put out there and it's like, I think sort of to Dr. Chan's point too, is like, it's kind of up to you to decide if you or I think you said the opposite actually. But it's for you to decide, like when you're reading something, how close are you to that person,
Can you do it in an unbiased manner?
And the other committee members see these disclosures, is that right? Kathy, or who views the disclosure statements?
We didn't review that. We didn't.
Yeah.
Last year.
Yeah, we
Yeah.
submitted them
Submitted them.
to Kathy and whoever was still at the time.
No, Scylla, I don't think was here. It was
Yeah,
Tamara.
whoever was in the
Tamara,
position
yeah.
prior.
Would it be helpful to see each other's disclosure statements, or that's something that we can just available?
I was looking for guidance. I mean, there's
Okay.
ones that I thought perhaps the guy had an employee, a director, a family member was, so I thought, okay, is that, I don't know them personally, but they're the spouse of someone who reports me. So it was that kind of gray area. And I think that the conflict of interest form covered everything.
Yeah,
So
that
a little bit of.
It was,
Yeah.
it was two.
Got
We're
it.
not gonna use it. I think we established, we're not gonna use a conflict of interest. We have a disclosure statement. And I think it's up to you all, or Brandon, that's up to you. Do you think that maybe we just if it's a personal, like a very close personal relationship, maybe that would be something that you might wanna,
Just some definition, as long as. we
Yeah,
have
I
it.
don't, I would say in Rhode Island with colleagues, I've worked with a lot of people. I don't know.
Yeah.
I'd have a
Yeah.
conflict with everybody.
Yeah.
Yeah.
Different than having.
Oh, it's okay.
conflict with
That's
everyone.
helpful.
And then what I might recommend is that we, rather than maybe circulate all of the disclosure statements, we just have them accessible. And then when we go into our executive session, that is when you maybe would reveal that you would want to disclose some sort of relationship when we're discussing the application, if that makes sense, in that encounter session. So yeah, let's do that. We'll put together a definition. And if you want to generate your own statements, and then we'll be ready to share those as we discuss the applications. Yeah. But I'm tempted to agree, Kathy. I think like it's more personal relationships, Alex, to your point, than professional, because we're such a small state. It's,
That's
Yeah.
helpful.
yeah, Maria.
Okay, I can say in real estate, we use the disclosure for family and friends.
Yeah.
Or someone related to you, so that cover everything.
Yep.
I think so.
Family and
So we
friends.
use in real estate,
Yep, family and friends. So we'll keep it
family
simple.
and friends.
Yeah.
Well, the other is, I think the statute on other disclosures has a business associate, a partner in a business with somebody else. There's an interest then sometimes to, you have a conflict of interest. You jointly own property, or you're investing together, or whatever. So you have business relationships that then you have to disclose, as well as getting numbers.
Okay.
We'll
Yeah,
put
it's
this in
just
writing.
disclosing anyway. It
Yeah.
doesn't mean that, yeah.
Yeah.
Okay,
Great point. Okay.
all right, thank you.
Other comments on the process that we'll go through in March? This is coming up March 25th, so that's right. Okay, so yeah.
Can I ask a process question? Because I think that Adi had done it for the office last year, but were the applications sent out to the committee to review in advance?
Yes.
And that's how it'll be done this year?
Yeah, I think I gave a timeline. I don't know if it's on the slides.
Yeah.
For you all, we determined this, I typed it somewhere, but they're due on February 27th, and then I will get those out to you, by the Wednesday following, or our team will, and then we'll give you approximately 10 days, I think it was. Let me look at the dates,
2 weeks.
because I made it, 2
Yeah.
weeks. To just give us your top 5 or your votes. And then, we'll have the packet together to go into executive, bring them here, listen to some of the top 5 folks for the 2 open seats, and then we'll go into executive session. So the 27th, and then we will have these out to you by the 4th of March. And then we ask that they're back to us by the 20th.
That's right.
I'll send instructions out. I didn't want to just send it out before the meeting and then confuse everybody. We wanted to announce it first.
Kathy, are you saying that there could be a potential of 10 people that present?
No, 5. We're gonna.
Five in
ask
each
for the
category?
5.
Yeah.
Well,
Each category.
isn't
or-
that what we did last year? It's
I
5.
think we did do 10 total.
Yeah, we did. It was 2
Okay.
minutes.
2 minutes
Hang on,
each.
but-
Yeah.
Okay.
Yeah. We could do less, Director, if you think that's too many presentations.
Depends what the gap is. If you feel you need to fill 5, then, but if there's consensus around 3, and the top 3, and then the trails off, then I don't feel that we have to be compelled to do 5, but that's up to you.
Mhm.
It's just that 10 people is a fair amount of presentation.
Yeah.
I think it all really depends on how many applications we get in. We did get a lot of applications over the past couple of years.
It's good.
And I know that, I did speak to, because I know Miko and Dennis both aren't here. I did speak to both of them personally and reminded them that they can reapply.
Yeah.
If they wanted to. And also if you want to just spread the word, we're spreading the word through the task force, through our newsletter, through our work groups. Also, right now, we put it in the chat here, that it's on the Executive Office of Health and Human Service opioid settlement page, the application.
And can we send that link out to the committee members?
Yeah, and we'll do that.
And as you're circulating that link in the application form, some things to keep in mind are that they're all now 2-year terms. Dennis was the last term that was more than 2 years. And the expectation, as you all know, is in-person attendance because of the Open Meetings Act. So You can join remotely, but you can't participate. You have to be in person. So we expect people to be present for most or all, ideally, of the in-person meetings. So I know that can be a challenge, but something to remind folks about.
And I'm only kidding, but it's true. And just unfortunately, because of the state fiscal year, we have most of our meetings in the summer.
Yeah. As you all know.
It's true, true story.
Okay. Thanks all. This is really helpful feedback. We'll work on a definition for the disclosure statements. That's a great one, and get that out to you. Thank you, Kathy. We're going to turn these around quickly. Yeah. Okay. Great. Any other questions, comments? If not, we'll move into our second public comment. Anything on Teams, Kathy, or so?
Does anybody on Teams have anything that they would like to share? Just raise your hand or you can come off mute.
In the room. Great. So we'll finish then with just a few updates from Kathy on the task force. What is going on? And this slide is a little outdated. Apologies to the committee.
I updated,
Yeah.
I did update it a little bit, so
Great.
I do apologize that it's a little outdated because it was for January. So in our January Governor's Overdose Task Force, we did look at, we had an update from our partners at the Department of Health on the Essence system, which is the non-fatal overdose spike alert system, which they're very excited about. It's going to get us a little bit better data. And then we also had the presentation that you saw sort of a high level of for the accidental fatal overdose data for the first 6 months of 2025. And, you know, again, I can't reiterate more that we've already, if we're still in this trend, our goal for 2030 is to reduce fatal overdoses by 30%. And we are already past that. If it is at, in fact, 33 to 40% reduction. And then we also had an update from our Overdose Data Council. You all saw sort of a snapshot of that in our October meeting. I know it was a while ago, but that was basically, it was updated data for calendar year 2025. And it really tried to show like what we call the scorecard. How are we doing across all the pillars? Because this is, and this committee and your just recommendations and the decisions that are accepted by the secretary for the portion that is opioid settlement is helping to drive that information as well. So, and then last month or last week, we had, the theme was Black History Month. It was an amazing Governor's Overdose Task Force. We had a few folks that joined us. So we had Valerie, the Rhode Island Black Storytellers. That was actually Sil who helped to bring that person to us. And it was amazing to see the work that she is doing out in the community, mostly in the city of Providence. And then we also had Dr. Hernandez, who joined us, and he really told us about the history of institutional racism and the impact of discrimination and racism across the country and in our state specifically. We actually, like, just to give you a little idea of how good this was and how engaged it was, is that we stayed on for an extra 15 minutes. And about, by the time we closed it, it was over 40 people still stayed after. It was 120 that were engaged in the whole thing. And then in March, we're going to be focusing on Women's History Month. We've asked the Women's Policy Institute or Women's Fund to join us and give us an update and just kind of share some of what they're doing. And then the second presentation, we've just asked Safe Spot. So that is Stephen Murray. If you haven't ever seen him speak, he's an amazing speaker and he's leading Safe Spot. And he's going to give us a presentation on the Safe Spot. It's sort of like, it's not never use alone, but it's that concept as a description to the task force. And he's going to share some of the highlights from our New England partners who are invested in that. So that's all I have.
Kathy. Okay, folks, so that's all we have for you. As promised, we'll maybe get out of here a little bit early. Our next meeting is March 25th in this room from 1 to 3. We're going to be doing the presentations and the voting of the new members, so that may take most of the meeting. But if there's any other agenda items you'd like to see or discussion you'd like to have, please email me. My email's on the last slide. You could go ahead and do so. If we have any updates on Purdue, we will offer those to you at that meeting as well. So that's the plan, folks. Yeah, Linda, one more.
Sorry.
Sure.
I just wanted to make an announcement, particularly for this group. Kodak, in partnership with the Rhode Island Public Health Association, has started a series of programs for community members, all of us, whoever is helping in this. And we've had 2 so far, and they were really well received. I'm happy about that. And the next one is probably going to be in 5 weeks. And it's going to be, we're going to focus on the medical components of the relaxed regulations for opioid treatment, which means we're just talking about if someone is utilizing buprenorphine or opioids, the regulatory criteria have been remarkably relaxed and are far more clinically indicated than whatever we have experienced in the past. It's really great. One of the things that's holding us back is many of us have been in the field like me for like decades and decades and decades. So we're hanging on to the old DEA regulatory structures. So we're going to help the docs and the nurses and all of our teams kind of shed that and hear that it's safe to respect the autonomy of the people that come to us for care. And so we're going to have the 3rd one. They've been really well received. The last one we had 220 people. I mean, it's really exciting. And I don't know if it's okay, but can I offer this to the group? I thought that I'd sent it out, but I think we got a little mixed up over on my admin side. So I don't know that you got the invitation. But may I provide that with Jeff's comment?
Yeah.
Cool.
Yeah, we
So
can definitely
thank
share information. Yeah, thank you, Linda. All right, can I get a motion to adjourn? Oh,
moved.
hi, Tom. Yeah.
Thanks for joining
Yeah,
us,
how
Tom.
did you sneak in?
I saw.
You're right, Patricia.
We've got a question. Would you say that the regulations were relaxed or modernized?
I would say they're both. I think they were modernized, which resulted in relaxation.
Okay.
Exactly.
Yeah, I just think it's important.
I like, no, modernized is good. Yeah,
Because I think, we've learned so much
yep.
over the years and they weren't touched in 20 years. So they needed to be updated.
See.
Thanks for joining us, Tom.
It's great to be here. Nice meeting you. Thank you.
With that, can I get a motion to adjourn? Patricia, a
So
second?
moved.
Yes, and all in favor?
Aye.
Any opposed or nay? Say that. Great, thanks all. We'll see you in March. Take care.
Yes.
Good.